So, just going through the flow chart, we all know we have talked about PPH. So, going through the flow chart, as we just talked in the previous session, if there's a massive hemorrhage, we have to see ABC, and simultaneously we have to give uterotonics, send the investigations, put the whiteboard cannula, and start the resuscitation if required, and also look for the cause. So, when we look for the cause, first thing we see is the tone. So what maneuvers I'm talking about is practically useful for improving the tone, which is the major cause of PPH. Atonic PPH contributes to 70% of the PPH. So this tone we will assess, and if it is boggy, we can start massaging the uterus simultaneously with the uterotonics. So it can be abdominal way of massaging or a bimanual compression, and further on, if that is not effective in improving the tone, we can go to the uterine balloon tamponade. These are mechanical methods, can be initiated early before we are thinking of shifting to this for surgery, and quite often they are very effective, but monitoring is required. It is not that 100% they are effective, so you might need surgical intervention. So be prepared for surgical intervention and start these maneuvers, which can be done very easily. So the fundal massage is the one which can be done per abdominal. One hand is placed on the lower abdomen at the level of the pubic symphysis to stabilize the uterus, and with the other hand you massage it, or simply with one hand also we start massaging the uterus and see for the tone. And if it is not, the tone is not good, start with the bimanual compression. For this we introduce a hand straight and with the thumb across the palm, and go pointing laterally towards the thigh, and go to the anterior fornix and make a fist with your thumb above, and press the fist against the lower segment, and the other hand should compress the upper abdominal hand should compress the fundus, go behind the fundus and nicely compress between your two hands to maintain that compression for some time for the tone to improve. So that is how we do a bimanual compression. You can intermittently release also, but there are two ways of doing it. You can continuously press it also to improve the tone. So this is just a demonstration. Now coming to the internal uterine balloon tamponade. The indications, as I said, was atonic postpartum hemorrhage, which is unresponsive to medical management, and before we are thinking of interventional radiological procedures or surgical intervention. But there are few prerequisites before you think of doing a balloon, that you should have the trained personnel for putting the balloon, and by and large we should rule out the other causes, because if there are other causes it will not be effective. It is effective for atonic PPH. Maternal status has to be monitored, so you should put it in a facility where you can monitor the maternal status, and where for escalation of services are available. That means if you need blood transfusion, you need surgical intervention, you have those services. So that backup service should be there before you think of putting this. So this procedure is that first we catheterize the patient, remove, then you do PV examination, remove the clots. Then we prepare the balloon. You can prepare a condom catheter, you can make the Chhattisgarh catheter, or you have a Bakri balloon. So in the balloon, we know all the condom catheter. I think it's very simple. You over the this thing, Foley's catheter, you put at the tip, you put a condom and tie it with silk. And then with the where the you put the Eurobag normally, that channel you have to put the IV fluid line, and it inflates. The balloon can be inflated from 300 to 500, but not more than 500. And you can check and then deflate and put it. You do a PV examination, remove the clots, see the cervix. Usually you need not hold the cervix, it's visible. Or you can put a SIM speculum and an AV retractor to visualize the cervix and introduce the balloon with the Foley's. And the entire balloon should go above the internal os of the cervix. And after that, we inflate the balloon slowly and till a maximum of 500 ml, and after that we pack the vagina to prevent any expulsion. And then the main thing is, after this we have to monitor. So after this, the main thing is, after this, the monitoring. You have to see whether your tamponade is causing the desired effect, whether the bleeding has stopped. If the bleeding has stopped, we are satisfied. But if the bleeding has not stopped, then you again have to look for other causes. Maybe your balloon tamponade is not effective. You have to escalate to other means, like your surgical methods. And you have to also see if it is not, suppose it is not effective, whether your balloon has not got deflated or it is not positioned properly. That can be checked by a point of care ultrasound also. And one more thing which is important to do is actually mark the fundal height and see for the increase in fundal height. Sometimes blood is collecting inside the uterus, it's not coming out because your balloon is there at the internal os and is collecting. She is becoming, the hemodynamics is becoming worse, but you are thinking there is no blood coming out. So you are happy, but that should not be the cause. Monitor the fundal height. If it is increasing, then the blood is collecting inside the uterus. So the balloon tamponade, the condom catheter, it is very easy to prepare, but the drawback is we don't have an outflow channel. Whereas the Bakri balloon, it has an inflow and an outflow. So you can, the drainage channel can be attached to a drainage bag and you know how much blood is coming out. So, but in the Bakri balloon, in the Foley's, you cannot do that. But the Chhattisgarh is the modification with the balloon and the balloon and the condom, where you can create an outflow and an inflow with this same assembly. Like the bulb portion that is punctured, and through that bulb the inflow goes, and the outflow is made from the one which is attached to the urobag. So that assembly itself can be also used to make a outflow and an inflow. So that was in the this thing video, but unfortunately it's not playing. So we have to assess amount of blood loss, whether it's collecting inside the uterus or it is coming through the bag. And if it is, suppose the fundal height is increasing and nothing is coming out through the outflow, you can flush the outflow and then see, remove the clots and see whether it's draining out. And if it is continuously pouring, she's not responding, then think of coagulopathies, you know. So it is good to actually check your, go for your labs, do your rotum and TEG if you have, to know how much, what replacement has to be given, and escalate the services if your tamponade is not working. Patient should be shifted to HDU or ICU if you think of coagulopathy, and you call in your hematologist and other critical care intensivist and others to help with the coagulopathy. And simultaneously the oxytocin has to be continued, and that is important. So my conclusion, very crisp and small talk, because of the videos I think it has become smaller. So uterine massage is a very easy and effective method to manage atonic PPH at its initial stage, and commence it early rather than late, and continue your oxytocin and medical management along with that. Uterine balloon tamponade is the second stage after your massage is not functioning, then you can go for your uterine balloon tamponade. It is also a very effective mechanical treatment for atonic PPH which is not responding to oxytocin. But following UPT, you have to monitor for the response to tamponade, and if it is not effective, then escalate yours to the higher level, to the surgical management, to prevent irreversible hemorrhagic shock. And simultaneously you have to initiate your transfusion protocols and your blood and blood product replacement therapy. So thank you so much for your patient hearing.